So now we finished the knee and we're going to switch gears and learn about the hip. And we're very lucky to have with us today Dr. Stephanie Wong. She's going to teach us about common hip problems and then teach us how to examine it, examine the hip well. Stephanie has been with us for a few years since she finished her orthopedic surgery residency here. Then she went away for a year to do a fellowship and then at Rush University in Chicago. And that was in sports medicine, surgery fellowship and hip arthroscopy. Then she came back to work with us and she specializes in arthroscopic treatment of hip, shoulder, and knee injuries. Her clinical expertise involves hip labral tears, femoral acetabular impingement, glute tears, hamstring injuries, and then she also treats sports conditions in the knee and shoulder. So we're happy to have her and we can't wait to hear her talk. And thank you very much, Stephanie.
Hi, everybody. We're really excited to have you all here today. Thank you, Dr. Wing, for that great introduction. So I'm just going to go ahead and get started. No disclosures for myself. So the objectives of today's talk is to go over common causes of hip pain as well as hip injuries, identify the indications for obtaining proper diagnostic tests such as imaging, and then finally to go over the non-surgical as well as surgical management of various hip conditions. So in terms of the top three things that I would ask a hip patient, they're pretty straightforward and probably part of your standard HPI, but I would say ask about the chronicity. So I want to know, is this an acute injury or has this been going on for a really long time, say months or years? Going along with that, usually I ask about a mechanism. Is there some sort of inciting event that caused this hip pain to start? Or are they a runner or other active person and they've been doing certain activity for a certain period of time and that seems to be associated with their pain? And then finally, location. And we'll go over this in a minute, but I think location is one of the most important things to ask when a patient's experiencing hip pain. And a lot of times the location will tell you where the pathology is. And sometimes it's more than one location, but we'll go over that soon. So here are the kind of three different locations, just to kind of simplify things that I think about when I think about the hip. So if a patient tells me that they have groin pain or anterior hip pain, a couple different possible causes of that would include femoral acetabular impingement, which I'll talk to you about in detail in a moment, flexor or adductor strains, hip osteoarthritis, hip dysplasia, avascular necrosis, or a stress fracture or stress reaction. Common causes of lateral hip pain include trochanteric pathology, including bursitis, gluteal tendon tears, as well as snapping hip or IT band syndrome. And then finally, more towards the back of the hip and pelvis, posterior-based hip pain can come from either the SI joint, hamstring injury, or tendinitis, and it also can be due to referred pain, such as from the low back or sciatic nerve. So we'll go over all of these just so you are more comfortable and familiar with these various conditions. So just to review some hip anatomy, here on the left is a diagram showing some of the bones. So the bones of the pelvis. And then I tell patients that the hip, is made of a ball and socket joint. So the ball being the femoral head and then the socket being the acetabulum. Off to the side here, you can see the labrum, which is a soft tissue bumper that goes around the hip socket. And then I will show you some pictures of what that looks like in the hip when we do surgery. And so that's some of the osteology. And then this bump on the side of the femur, lateral side of the femur, is a greater trochanter. And then that will become really important when we're talking about sources of lateral hip pain. And then finally, toward the bottom of the screen, we have the ischium. That's kind of your sit bone where you sit on, and that's also where the proximal hamstring originates. So looking here at some of the muscle groups, you'll have these in your syllabus just for your reference, but I like to just kind of review some of the various muscle groups that can be involved in hip conditions. So starting at the top, you have the iliopsoas, which is the iliacus plus the psoas, and they come down and attach on the lesser trochanter. Those are a really strong hip flexor. Mostly on this photo, you'll see the quadriceps muscle group, so the vastus muscles as well as the rectus femoris. And so these are muscles kind of crossing over the front of the hip joint. And then laterally, the tensor fasciae lata, which sounds kind of like a Starbucks drink, that's the muscle that originates off of the iliac crest and then comes down and then becomes confluent with the IT band as it comes down the lateral thigh. This is a view of the posterior hip. So we were talking earlier about how the hamstring tendons come up off the ischium. So you can see those here at the bottom of the pelvis. And the hamstrings are made of the semitendinosus, semimembranosus, as well as the biceps femoris. And those are the three large muscles that make up the posterior aspect of the thigh. So first I wanted to talk about femoroacetabular impingement, and then on the top right-hand side of your screen will be kind of a little legend of which part of the hip this condition refers pain to. So we're in the anterior or groin region right now. And so this condition occurs when you have repetitive abnormal contact of the acetabulum and the femoral head neck junction. So just like in this photo here, you can imagine that as you flex your hip up, this bump on the side of the femoral head can bump up against the socket. And then the labrum is a soft tissue structure sitting in between those two structures that gets damaged or torn kind of with that repetitive motion. This leads to mechanical stress as well as shear forces on the labrum and cartilage, and over time can cause damage to both of those. This can affect a wide range of patients from adolescents all the way into the middle age. And we think of this condition as kind of a developmental problem. So a lot of people develop this cam-type lesion, this bump on the side of the femoral head and neck during development as the bones mature. And then some people are born with an extra deep socket, which is called a pincer. And I'll show you some images of that in a moment. This is often a chronic condition. So most of the time I'll hear patients tell me that this started happening, some months or even years ago sometimes, no specific kind of inciting event or injury. Very high prevalence in athletes. So some studies report 70 to 90% prevalence of radiographic femoroacetabular impingement in elite hockey as well as football players. Not to say that they're all symptomatic, but oftentimes you will see that they will have X-ray findings of this condition. And ultimately, we care about this because it can cause intra-articular injury to the labrum and cartilage. And in younger patients down the line, this can unfortunately lead to conditions like hip arthritis. So this is something to be aware of in this patient population. So here's kind of what I was telling you about before in terms of the cam. So the cam is the bump, and you can kind of see in this video how you develop this bump on the femoral head neck. And then as you flex your hip up, it bumps up against the labrum. And over time, with this repeated mechanical stress, this can cause damage and tearing to the labrum. The labrum connects to the cartilage. And as the labrum tears, it can actually cause further damage to the cartilage or have injury propagate into the cartilage junction. So that's one type of femoroacetabular impingement. The other type we call pincer. So pincer is when the socket is extra deep. This is more of something that you were born with or that's the shape of your bones. This is more common in women, especially kind of in their 40s. So cam, aspherical, femoral head, like I said, and then mixed type. This is basically just a mixture of both pincer and cam, which can exist as well. So the hip labrum, this is a photo of it intraoperatively in a patient who has a labral tear. So the labrum is a protective ring of fibrocartilage, and it sits along the rim of the acetabulum, kind of goes around 270 degrees, and it helps to stabilize the hip, and it provides a suction seal as well for the joint. Labral tears are actually really common. So this study showed that over 90% of patients with femoroacetabular impingement do have a labral tear, so radiographic signs as well as exam findings. And then interestingly, a study of asymptomatic patients done by Dr. Philippon out of Vail showed that over 70% of patients had a labral tear. And interestingly, I think this was a study of his fellows and their significant others, asymptomatic patients. So I tell people that it's really kind of it's a clinical syndrome. So their symptoms have to match, their exam has to match the imaging findings. And then finally, sometimes we see isolated labral tears in patients over the age of 65 without a cam or pincer bony deformity. And these can be normal findings and or degeneration of that tissue. So another thing to keep in mind as well. So how does femoroacetabular impingement present? So patients will describe groin pain, or they might take their hand, like in this photo, make a C shape, and then put it around kind of the front of their hip, wrapping around posteriorly. Commonly worse with sitting as well as with activity. On exam, which we'll show you in the exam session soon, they have a positive fader sign, which stands for flexion, adduction, and internal rotation. We get x-rays, so an AP pelvis and then some sort of lateral of the hip is helpful. And then, let me go back here. And then advanced imaging would include an MRI versus an MR arthrogram, especially for those patients who have tried non-operative management and still have pain. In terms of which study to get, I will usually get an regular MRI if it's going to be a 3 Tesla scan. An MR arthrogram is a good option for 1.5 Tesla machines, or if you're not sure, that involves an injection of dye as well as usually local anesthetic into the hip, and it distends the hip capsule, makes the labral test a little bit more obvious. So this is a coronal cut of an MRI of the right hip showing the femoral head, acetabulum, and then you can see the black triangle off to the side of the acetabulum is the labrum, and you can see how there's white signal going between the acetabulum and the black triangle. So that's the tear right there. So like I said, all patients that have femoroacetabular impingement, we treat non-operatively to start, but the vast majority of patients can get better with non-operative treatment. So we talk about things like medications for pain management, NSAIDs are helpful, as well as physical therapy, primarily for core and gluteal strengthening. So I really like, kind of a Pilates-based program for this. And then you can also consider an injection into the hip. For example, a corticosteroid injection can help relieve pain if the patient's having enough pain that they are having trouble doing the physical therapy activities, or this can also be both a treatment tool as well as a diagnostic tool. So if they get better with an injection to the hip, then you can say there's an intra-articular source of their symptoms. Finally, for those patients that fail non-operative management, we consider surgery. The surgery we do for this condition is called hip arthroscopy, so going inside with a camera. We do the labral repair if the labral tissue is good quality, and then the osteochondroplasty. So that's trimming back any prominent bone on the femur side or the acetabulum side. So here's some intraoperative pictures of a labral repair. Just to get you oriented, this is a right hip image, and we're looking in from the lateral side. On the far right-hand side of your screen is the femoral head, which is distracted out of the joint using traction. And then the 2 blue sutures are looped around the labrum to sew it back up to the socket. This is a picture of the osteochondroplasty. So after we do the labral repair portion of the procedure, we'll take the hip off of traction, let the femoral head go back into the acetabulum. And then you can appreciate how this patient has kind of a bony deformity or cam lesion. And so we're going to take a burr and gently plane that down to make a more spherical shape. This is that same patient just from a different angle. And then this is kind of the end result there. So how do patients do with non-operative treatment versus operative treatment? So the UK fashion trial was a really nice study published out of Lancet in 2018, comparing and randomizing patients to either PT or hip arthroscopy. This is a multi-center study that included almost 350 patients. And again, randomized them to hip arthroscopy versus PT for FAI. The crossover rate from PT to surgery was about 8% in this study, and they did an intent to treat analysis. And overall, you can see from this graph here, and they looked at the IHOT score, which is a patient-reported outcome for hip, that both groups did improve compared to their baseline. However, the surgery group by the 12-month mark did improve more than the non-operative group. So I share this data with my patients, and I tell them that there's, both treatments potentially would lead to a good improvement. The surgery group does tend to improve more for pure kind of femoroacetabular impingement syndrome. So when do patients get better once we do a hip arthroscopy? So this was a study done here at UCSF, led by one of my colleagues, Dr. Alan Zhang, that looked at 129 patients undergoing hip arthroscopy here. They all had 2-year follow-up. Their mean improvement in their patient-reported outcome scores is listed here. And then in terms of the percent of patients achieving MCID for the patient-reported outcome we call HOOS, you can see that at the 1 year post-op mark that the vast majority of them, 80+% did have improvement that reached the MCID. But then if you look at the 2 year mark, that you see that some additional patients improve from the 1 year to the 2 year time point. So I also tell my patients this, that often will let patients go back to full activities about 6 months after the surgery, but patients do continue to improve in terms of their symptoms, pain, and function at 1 year and even out to 2 years. Switching gears a bit now, another common cause of anterior hip pain includes muscle strains. So this is one of the most common injuries in the hip and pelvis, occurs at the muscle tendon junction, and is often described as an acute injury. So they'll say they hear a pop, they felt some bruising, they were sprinting or playing some sort of sport. And anteriorly, we think of the hip flexors as well as the quad. Medial thigh is the adductor group, and then posteriorly you have the hamstrings. So really, really common injury. And so non-operative treatment is really the mainstay, and most of these injuries occur in the muscle belly. So if you have any concern about more of an avulsion, like the tendon pulling off of the bone or pulling a piece of bone off with it, don't be afraid to get an X-ray of that limb just to make sure that it's within the muscle itself and not involving bone. But for muscle strains in the muscle belly, non-operative treatment is really kind of the standard of care with rest, ice, compression, and anti-inflammatories, and then gentle range of motion and stretching to prevent stiffness is really important. These athletes and patients can advance their strengthening and return to activity once their pain is improved. And oftentimes return to play in sports occurs within 1 to 4 weeks of this injury. Another common cause of groin pain or anterior hip pain is hip arthritis. This affects many millions of patients annually, and this is often, again, described as a chronic groin pain. So this is why I think x-rays are so important. Sometimes I see early onset osteoarthritis in my clinic, so I do really, insist on patients getting x-rays because that can easily rule out conditions such as arthritis or rule in. Patients will usually describe for this condition an achy pain or a stiffness, and that's in contrast to FAI, which may be more described as a sharp pain or pinching type sensation. They may have difficulty walking longer distances, difficulty putting on their shoes and socks, difficulty with stairs. And on exam, they often will have limited hip range of motion. So compare this to the opposite side, and we'll show you today during the physical exam session what to expect in terms of a normal range of motion for the hip. The x-rays here, you can see this APV of the pelvis showing joint space narrowing, osteophytosis or bone spur formation, as well as sclerosis or an increased whitening of the bone. So these are all classic signs for osteoarthritis. And you can compare these to a normal hip, which is this image seen below. So in terms of non-operative treatments, there are several that have been, received a strong recommendation from the AAOS clinical practice guidelines, which include anti-inflammatories or NSAIDs, steroid injection, and physical therapy. So you can kind of see some of these here. In terms of the steroid injection, these can be done 2 different ways. I recommend image guided for any hip intra-articular injection because this is not a reliable injection to do based on landmarks because of the depth of the hip as well as adjacent neurovascular structures, including the femoral neurovascular bundle. So on the left here, you can see a fluoroscopically guided image. They put some dye in, so contrast so that you can see that this went into the hip joint. And then on the right-hand side, you see an ultrasound guided image. Either of these are acceptable, but it should be something image guided. Finally, weight loss I added in here as well. I think this is really important for patients that are overweight or obese in terms of decreasing their, pain in the joints, especially the lower extremity. Finally, in terms of operative treatment, total hip replacement is a very durable and reliable option for those who have failed non-operative management. This is what hip replacement looks like. So essentially, you have a metal socket a metal ball or ceramic ball, but some sort of hard substance with a stem that goes down into the femur. And then in the middle, you have a plastic liner, and that takes the place of your cartilage. This is what a picture of a total hip replacement looks like on X-ray. Overall, the outcomes are really excellent. So over 90%, excellent outcomes, and survivorship ranges between 15 to 25 years. And this overall has been improving with the improvements of some of the materials used in these replacement surgeries. Another condition I commonly see is something called hip dysplasia. So hip dysplasia, as you may know, those of you who care for some pediatric patients especially, is a developmental problem that is an issue with the acetabulum not being deep enough, so shallow acetabulum. This is a photo here showing a hip located on the left-hand side, and then some of the most severe hip dysplasia patients having such a shallow hip socket that the head of the femur actually dislocates. And then if you remember back to those of you that care for infants, and for those of us from our pediatrics rotations long ago, Barlow and Ortolani maneuver in infants will diagnose this issue. Occasionally, I'll see patients with more mild forms of hip dysplasia that don't have a positive exam, and they may not be diagnosed until a little bit later in life, maybe in their 20s, 30s, or 40s. Risk factors include female sex, breech presentation, as well as a positive family history. And I think I already mentioned this before, but mild dysplasia may be asymptomatic until adulthood. So again, another good reason to get an X-ray, because an X-ray will show you this. And that's pretty straightforward. So why do we care if a patient has mild dysplasia? So they're not dislocating, they don't need treatment as an infant or child. We care because the natural history is really poor. So early onset arthritis. So sometimes when I see patients with mild hip dysplasia, they're in their 40s, they're really considered to be young to have arthritis. But if we had caught their mild hip dysplasia earlier, there are some interventions that we can do to try to prolong the life of their native hip. And so this is another image of a patient with hip dysplasia. So you can kind of see here on this X-ray that the ball just doesn't look like it's all the way covered. It's almost like a very shallow roof, and a roof does not extend all the way over the ball. These patients will present very similarly to FAI patients. So groin pain, usually younger patients. They might have a positive fader as well. Treatment for these patients, you can start with a non-operative treatment, including physical therapy, lots of core, glute strengthening, as well as pelvic stability exercises. But we know that the surgery does change the natural history of this condition. So nowadays, as part of our hip preservation center, I collaborate with some of my colleagues who do pediatric surgery for these patients, and we do a combination approach, including a hip arthroscopy to repair the labrum, which is often torn in these patients, and something called a periacetabular osteotomy, which changes the 3D coverage of the femoral head. So periacetabular means around the acetabulum, osteotomy means to cut the bone. So this is a surgery where the acetabulum is cut out of the pelvis, rotated over, and then fixed with screws. So you can see an example of this on this X-ray below. So this restores more of a normal anatomy for the hip joint. And this does prolong the lifespan of this hip before the natural history, which is arthritis, develops. Another common condition that we will see causing hip or groin pain includes avascular necrosis. So AVN is due to decreased blood supply to the femoral head, which causes the bone to actually die, the necrosis part. Risk factors include oral steroid use, trauma, some medications, including protease inhibitors, alcoholism, but many cases are idiopathic, so we don't know exactly why some patients develop this condition. On X-rays, you might see lucency in the femoral head, so or collapse of the femoral head. So you can see here on this X-ray that there's some kind of lucent bubbles kind of up in the femoral head near the weight-bearing surface. So that would be diagnostic for avascular necrosis. And then we usually recommend an MRI to stage. So if you see femoral head lucencies, An MRI is a good idea, and I would recommend an MRI of the pelvis because about 80% of patients that have AVN on one hip will have it on the other side. So it's good to know. Sometimes people are asymptomatic in the early stages. So this is what it appears like on the MRI. So you can kind of see this serpiginous black line. That's the area of bone that's abnormal and have abnormal blood supply. So treatment for these patients, physical therapy can often help with hip pain, steroid injection as well, intra-articular, like we talked about before. And then some patients are candidates for core decompression. These are all pre-collapse patients, so the ball still needs to be round. If the ball has collapsed down, so the architecture of the bone is weakened because the bone has died, then those patients are better candidates for total hip replacement. So this is a patient I treated for avascular necrosis. You can kind of see these areas of mixed kind of lytic and sclerotic areas in the head. This is what it looked like on the MRI. This kind of matches. And then we did this. So we did a core decompression. So basically that's drilling up into the lesion to try to stimulate more blood flow. Another condition I commonly see is stress fractures. So these can occur anywhere in the hip or pelvis. And one of the areas we care about the most is the femoral neck region. Oftentimes these patients will describe kind of overloading of the hip or pelvis. So really common in runners. And often I've also seen it in people who are doing kind of HIIT training or exercise classes where they're doing a lot of jumping or loading. This can occur in the femoral neck, sacrum, or other areas of the pelvis, like we talked about. Femoral neck we care a lot about because stress fractures can go on to become displaced femoral neck fractures, which then necessitate emergency surgery. So that's one of the regions that we care about the most. So this is an MRI looking at a patient that I treated who has a stress reaction in her femoral neck. And so I often will also ask these patients, check for increased loading. So ask them, what's your exercise routine like? Are you training for any races or events? Any new changes to your exercise regimen? Also assess for disordered eating, history of stress fractures, the other thing that will really predict future stress reactions or stress injuries. The exam maneuver for this, so a lot of them will be positive with various other things that cause intra-articular pain, but I think the best test I've learned is pain with a single leg hop. So just have them hop up and down on a single leg. If that causes them pain or if they're limping into your clinic, those are people that I would get an X-ray to start and then an MRI to rule this out. So like I said, low threshold to obtain advanced imaging. And then the treatment for this, if you diagnose this on MRI, is offloading. So crutches and being off of this hip for 4 to 6 weeks and then reevaluating. If they continue to have pain despite offloading, then I recommend surgery. And surgery is what we call percutaneous screw fixation. So stabilizing this region and allowing it to heal using these free cannulated screws. Also, after this surgery, patients are on crutches for a period of time. So I think that additional rest also does help treat this problem. So now moving on to some of the lateral hip structures and lateral causes of pain. Here on this diagram, you see the gluteus medius muscle, and then it comes down and attaches onto the greater trochanter. You also have the IT band, and you can see how these two structures can cause friction points around the greater trochanter, which we call trochanteric bursitis. Gluteal tendon, as it attaches onto the greater trochanter, can also have tears. So I refer to this kind of as a rotator cuff of the hip. So just think about it similarly to how you would in the shoulder. And then finally, IT band syndrome, or tightness over the IT band. External snapping hip is a condition where the IT band, if it's really tight, can kind of snap and pop over the side of the greater trochanter. So we also see that as well as a lateral cause of hip pain. For patients with trochanteric bursitis, this is an inflamed trochanteric bursa, really common in patients of all ages, but especially females aged 40 to 70. They present with pain over the lateral hip and pain when sleeping on their side. They will have tenderness right over the trochanter, which I'll show you in a minute on the exam. And they should not have any weakness of their gluteal muscles, so no hip abduction weakness. And in terms of treatment, non-operative treatment is the mainstay. So stretching of the IT band, physical therapy, an injection right over the greater trochanter can often help. But if they continue to have pain, an endoscopic resectomy to treat this is also an option. Now, sometimes coexisting with trochanteric bursitis is a gluteal tendon tear. These can be acute or chronic, often in the similar age range patients, but look out for weakness with hip abduction. They will also have a positive Trendelenburg sign, which if you look in my hip exam syllabus slides, you'll see an example of that. So again, caution, because oftentimes this coexists with bursitis, and you want to make sure you're treating, if it's a tear, then we think about considering surgery if they're failing non-operative management. The treatment options are similar to trochanteric bursitis, and the operative treatment would be repair. We call this endoscopic repair. So again, it's very similar to a rotator cuff repair type surgery, or open, depending on the level of retraction of the injury or the tear. For IT band or snapping hip, this causes a chronic lateral thigh pain, a wide range of patients, age 15 to 50, especially in runners and bikers. And when the IT band's really tight, then you get that external snapping hip. Treatment is commonly non-operative, so anti-inflammatories, lots of stretching, myofascial release, for example, cupping and foam rolling is really helpful. And then operative treatment includes IT band release, which can be done endoscopically. So this is an intraoperative photo of one I did recently, where essentially this white thick band here is your IT band. So we basically cut a kind of diamond shaped window in the IT band, and that helps alleviate this pain. So now moving on to the posterior area of the pelvis, which is kind of our last geographic area. Really common cause of pain in this region is the SI joint. So we think about acute versus chronic causes. Most commonly chronic pain, but you can also have patients that have sustained trauma, have inflammatory arthritis, such as ankylosing spondylitis, and they can also have arthritis in this region. They usually point to pain posteriorly, so over the lower back, off of the midline. They can have a positive Faber, so flexion, abduction, and external rotation test, which we'll show you in a moment. And non-operative treatment is really, again, the mainstay for this condition with these treatments below. SI joint injections are possible, often under image guidance, and then radiofrequency ablation if they have relief with the temporary steroid injection. Finally, an SI joint fusion is an option. There is mixed evidence in the literature about this procedure, but essentially, some patients do get relief. We talked about the proximal hamstrings earlier, and one condition I wanted to bring up is a proximal hamstring rupture or injury. So for proximal hamstring tendonitis, that often presents with more of like a chronic type presentation, but with ruptures, they usually are acute. So the patients will describe some sort of awkward fall. Maybe they were water skiing, they slipped on a wet floor, or their legs went into the splits. They usually have extensive bruising, similar to this photo. They can describe buttock pain when they sit, because again, that's right where the ischium is, where the hamstrings originate. And they'll often be tender right up that ischium, and they'll have weakness with knee flexion and hip extension, which is the action of the hamstring muscle group. I always recommend x-rays of the pelvis for these patients to rule out an ischial avulsion fracture, followed by an MRI of the hamstring. So this MRI, you can see, this is a corona looking at the right hip, and you can see a lot of edema, all the white signal within the muscle belly. And then the tendons are the two little black dots that you can see kind of towards the top of the thigh here. And those are avulsed or ruptured off of the ischium, their bone attachment. Some patients, non-operative treatment is an option with anti-inflammatories and physical therapy, just depending on the extent of the tear and their baseline level of activity. And for operative treatment, we do proximal hamstring repair. I tell patients that you're going to have sitting pain either way, so don't have the surgery just to get rid of the sitting pain. Here are some photos from a hamstring repair. So you can see here the ruptured hamstring tendon. We pass anchors into the ischium and then run the sutures that come out of the anchors up through the tendon, then use that to dock the tendon back down to the bone. The rehab is really intensive after this surgery. So it's 6 weeks in a brace with crutches or a walker. Physical therapy lasts for usually over 6 months, and full activity after the 6-month mark. And then finally, this may have been covered in some other sessions as well, but I often think about hip pain also being referred from the lumbar spine in some patients with conditions like lumbar disc herniations or lumbar radiculopathies. Especially patients that are over age 40, I ask them about pain going down past their knee into their foot, numbness and tingling, as well as low back pain. Treatment for these include physical therapy, steroid injections into the space around these inflamed nerves. Thank you so much. And please leave your questions and comments in the chat if you have any. Otherwise, we're going to move on and transition to the hip exam session.